Thank you, Tom. Thank you, Don. So as a California-based health plan, we recognize that in some respects we're fortunate. That California traditionally carries a lower population health burden than many other states. Our prevalence rates of obesity are consistently lower. Our prevalence rates of smoking are consistently lower, and other comorbidities. However, we also recognize that if you think about this from a clinical perspective, the delta between 1 in 3 Americans and 1 in 4 Californians is really a distinction without a difference. There's still a problem. The other thing we're acutely aware of as a California-based health plan, and as Californians, largely because we like to brag about it a lot, is that we're the 6th largest economy in the world, and for many intents and purposes, are a nation state unto ourselves. But what this means, particularly after November, but what this means in many instances is that the health status of your community varies dramatically in California based on where you live geographically. Right? If you were to start at the Pacific Ocean, anywhere between, say, San Diego and Mendocino, and drive 50 miles to the east, you would quickly leave behind Lululemon country, board shorts, and Teslas, and you would enter a part of California that reflects very closely other parts of this nation who are dealing with these chronic health issues. And so as a health plan with a mission, a goal to provide access to care worthy of our family and friends, we have to be aware of this and recognize that we have to be a part of the solution for these geographic, ethnic, and socioeconomic health disparities. Now, part of that is doing what a health plan is supposed to do, right? And actually cover clinical services. And I only have a few slides, and I promise you, I know it's after lunch, this is the only slide that has words on it. I know we're going to post-prandial here, you know, we got to keep it going, right? So in some respects, we do what a health plan should do. In other areas, we're acutely aware of where we could do better. And in other areas, we're aware that we might actually be differentiating ourselves. So with respect to member benefits, which Don teed up for us here, you know, we follow the Affordable Care Act compliance guidelines, offering $0 cost share preventive member benefits to our members in many different areas, obesity screening and counseling, right? I would say in large part, our provider community has come a long way in being more effective at doing obesity screening. All right, little sound effects here. Counseling is another matter, right? Historically, this is a chronically underutilized benefit, right? For a variety of reasons. I think from the provider perspective, it's really confusing to know what the benefit is, particularly when all the commercial health plans put a slightly different twist on it. They don't necessarily have referral networks built out to actually where to refer people for patients that need it. And oftentimes they report that they're still uncomfortable talking about it with their patients, and when they do, they don't feel like they do a great job of it. From the member perspective, you know, they too are confused. Right? Anybody who gets a EOB statement from your health insurance company knows that, you know, we can find 8 different ways to say something simple in a really complex way that confuses you. Right? And they also don't feel comfortable talking with their providers about obesity. So coverage doesn't necessarily mandate success in this space. Then we kind of turn our direction to treatment. I'm going to skip right to pharmacy. Right? So we cover a number of pharmaceutical interventions for obesity based on eligibility criteria and prior authorization and things like that. But as many of you also know who deal with health plans, who are members of health plans, pharmacy can get really, really confusing. There's brand, there's generic, there's tiering, there's copays, there's 8 million things that make pharmaceutical fills really complex. And my guess is it's a good number of Californians who figure it's a lot easier to go to a private weight loss clinic and get a prescription for their medications that way. It's just more convenient than dealing with the health plan. And finally, we cover bariatric surgery, again with certain conditions, and work with the Blue Cross Blue Shield of America Association on Blue Distinction Centers. But I think the take home on these 3 areas is we recognize that we're a health plan, we're not a provider. We are not in the business of delivering clinical services. That's the provider's job. Our best job is to pay for covered benefits in the most simple, straightforward ways possible, right? And to be as little of an obstructionist as possible as long as these interventions are clinically and cost effective. And that's no small ask for a health plan, right? We have been accused of occasionally being obstructionistic. We get it, right? Our hearts are in the right place. We're trying to do the right thing. Where we are quite okay with saying we actually want to help provide care is in the area of lifestyle medicine. It's because we believe that in the area of diet and lifestyle, the market solution isn't out there yet, right? And we're not saying it's anybody's fault. It's not the provider's fault. It's not the health and wellness industry's fault, right? But we believe there's a room to actually go out and do that. And when it comes to obesity, we have a kind of philosophy that we focus on it, but we don't fixate on it. We focus on it because we recognize all the numbers that have been shown today are really, really important about the increasing prevalence rates, the clinical comorbidities that come along with it, the fact that we still don't have like a slam dunk solution for it. So we still have to focus on it. But we also recognize as we deal with our members and our employer clients, we can't just fixate on it. Right? We actually have to be aware that we as public health professionals have raised kind of the language around an epidemic that is squarely bumped up against the popular health or popular opinion about obesity in a hyperfit culture which easily stigmatizes obesity and also recognizes that this attitude, that this is about willpower and that genetics and social determinants of health are academic exercises. And as this has slipped into the corporate wellness culture, it's very easy to go the wrong way. So for us, we've kind of paused, taken a step back and said it's important, but we can't just fixate on it. We have to recognize that obesity also isn't a solo traveler. It doesn't come along. I mean, if we want to get freaked out with statistics, there's plenty here. We can talk about we don't eat enough fruits and vegetables, we don't exercise enough, our obesity rate's too high, we have too many people on hypertensive drugs, high cholesterol, the diabetes rate is going up. But what gets us interested is that if you think about it from a diet and lifestyle perspective, right, the interventions for all of these bubbles on the right are largely the same. Right? And you could argue it should be 4 or 5 or 6 or 7. It doesn't really matter, but these are the usual suspects that we're talking about proven diet and lifestyle interventions. And so what we've asked ourselves is, if intensive lifestyle intervention is approvable as an FDA device, right, how come it's not working in the market? Right? There's a big discrepancy between what the research literature is showing and what is actually happening with our consumers, with our members, with average Americans. And so part of what we've stopped back and thought about is like, okay, there's some other things we need to think about. There's some other design principles we need to apply to our work. And I'm going to keep them really, really quick and really simple here because I'm already got yellow here. Right? The first of which is we really have to make this convenient. We have to make this convenient. People don't have a lot of time, right? And if we have a brick and mortar program that takes a long time to commute to and is a hassle to get to and takes a long time to park and get into, it's not going to work. So when we do brick and mortar programs, they have to be close, they have to be convenient, they have to be accessible. It also means embracing digital therapeutics, right? And actually getting on board that our solutions have to embrace mobile technologies, pads, phones, etc., and use Bluetooth-enabled devices like fitness trackers, scales, blood pressure cuffs when it makes sense. We have to connect people, either in person or digitally, to help build support networks so people can actually succeed. And lastly, our interventions have to be credible, actually proven, and actually have some randomized control or clinical published literature behind them. So here's a couple quick examples of what we're doing before I close out. Right? The first of which is a physical activity initiative, our Walkadoo program we launched to all members this year. Right? We fundamentally believe that if you're going to do this, you have to give it to everybody and it has to be free. Right? It's a mobile-based physical activity platform integrated with all the popular fitness trackers, Fitbit, Garmin, Jamo, and Apple Health Kit, et cetera, right? We use that data off those fitness trackers to deliver our personalized step goals via text or email. I'm not a big fan that fitness trackers in and of themselves will make any change. I actually don't think it does, right? But if it engages the consumer and it provides you personalized, contextualized data for you, not just 10,000 steps a day, there may actually be value with it. You can connect with your family and friends anywhere in the world. You don't have to be a Blue Shield member. You can be in San Francisco, London, New York. And what we're seeing is about 75% engagement, which is a really high rate for digital therapeutics. We believe that's part of the personalized contextualization of the program, as well as actually having people to support and connect with. And we have one small randomized control trial, right, showing that we have a 20% improvement in steps, about 1,000 steps per day. That doesn't look like much because this is specifically designed as an application for those people who have been largely sedentary or low active, looking to get active. There's plenty of apps out there for high fitness individuals. Strava, Nike Fit Club, et cetera, right? We felt there was a market need for those people challenged with physical activity. Lastly, we fully embraced the Centers for Disease Control Diabetes Prevention Initiative. We've rolled this out statewide to every single one of our members. We're not we're not marketing it as an obesity initiative, more as a diet and lifestyle intervention that will help you lose weight. To be comprehensive, we have approximately 600 community partners today. These are bricks and mortar locations in most of the California counties. We also provide multiple digital options, recognizing that people want to engage in different ways. And again, we use the technologies that are out there that help engage people and help also provide data back to us that actually document the outcomes from the program. So in closing, I'd just like to say we're trying to help this. We don't have all the answers. And a lot of times when you talk to somebody who's diet and lifestyle centric, you run the risk of them being just focused on diet and lifestyle. They're like, oh, we'll never use a drug, we'll never use a surgery. We don't have that approach. We believe it's the right solution for anybody. This is going to be multifactorial, multidisciplinary, but we firmly believe in raising the game on diet and lifestyle interventions that are clinically effective, cost-effective, come with virtually no side effects, no risks, and we want to make it free to everybody. Thank you.